Well, good evening, everyone, and it's my great privilege to welcome all of you once again for this Pearls of Wisdom session, which we have been doing all along. Well, you have been hearing lots of lectures and sessions related to the topics of urology and nephrology, but today we have a little different topic, and which will be very, very interesting. And the topic is related to pathology, and the title is Changing Face of Cancer. As you know, that the advances are taking place in the area of oncology and especially uro-oncology to the extent that what the cancer management was there and pathological perspective was there about a decade back is completely changed. And today we are going to listen to that, the changing face of the cancer, from a very fine speaker, Dr. Murli Varma. It's my great privilege to welcome Dr. Murli Varma, who did his MBBS from the University of Mumbai, from the Lokmanya Tilak Municipal Medical College. Then he did his MD Pathology from the PGI Chandigarh, which is one of the best center for pathology in the country. Then he went to UK and did his MRC Pathology in 1991 from the Royal College of Pathologists from the London, and did his FRC Pathology 99 from the Royal College of Pathologists, London, UK. He also did lots of fellowships from the USA, and now he is working as a consultant pathologist, histopathologist in the Cardiff Wells for very, very long time. Well, he has a very long CV. To cut the story short, he has lots of publications, more than 50 publications in the finest international journals of pathology. He is the member of various prestigious societies all across the world. To name few are the British Medical Association, British Association of Cytology, British Association of Urological Pathologists, European Network of Urological Pathologists, and so on and so forth. Well, over a period of years, he has restricted himself and he has super specialized, so to say, in the area of urology pathology. And even in the urological pathology, he has really subspecialized into the areas of prostate cancer. And if you see his publication and area of interest, he is extremely interested in the work and research in the pathology of the prostate and cancer prostate. Well, he's been a popular member to be sought after for giving lectures. He has delivered lectures, orations, guest lectures, conducted part in the various conferences and workshops all across the world. And today we are really privileged to have one of the finest speakers and the academician in the uropathology. Once again, I welcome Dr. Murli Varma for giving his talk in the Pearls of Wisdom session of the Changing Face of Cancer. Thank you.
Thank you, Dr. Sabnis. Thank you to the organizers for the invite. It's a pleasure to be here for multiple reasons. It's great to be here. It's always a pleasure to be in India, simply for the youngsters, that, the enthusiasm that I see. But it's a greater pleasure for me to speak to an audience of urologists. As a pathologist, I'm used to speaking to pathologists. I assure you it's much more interesting when we speak across specialities to exchange ideas. So I think the session is called Pearls of Wisdom. So I'll start with a pearl of wisdom that is not my own. So this is one of my favorite quotes from Socrates. I cannot teach anybody anything. I can only make them think. The point here is what I will be talking here is not stuff from the textbooks, right? So these are my opinions. These are my thoughts. Feel free to consider it. Feel free to reject it. But I hope that you will consider it and find at least some of it to be useful. The other point is that some of the things that I say to you might seem fairly obvious, but the implications of those are actually not as obvious as you might think. I think that this topic, the changing face of cancer, I could well have changed it to understanding cancer. So this is not about what the advances in cancer management or cancer understanding, but it's much more basic than that. What do we really mean by cancer? Right? So let's have a think. So we all know what cancer is. We all talk about cancer all of the time. Lay people know what cancer is. GPs, surgeons, oncologists know what cancer is. Pathologists know what cancer is. Scientists know what cancer is. But are we all talking about the same disease? Or actually, are we all talking about very different diseases? Is the very nature of the disease that we are calling cancer changing? And I would argue that the cancer that I diagnosed as a trainee about 30 years ago was an entirely different disease from what I diagnosed today as cancer. So we are talking about entirely different diseases. When I talk about a single tumor, a single patient's prostate cancer, is it a single disease? A single patient's breast cancer, is it one single cancer or is it actually several tumors? And then I think the most fundamental question of all, we have always been brought up to believe in this binary definition of benign and cancer. Is this correct? Is benign and cancer really entirely different diseases? I think these are things worth asking. And the reason why these questions are worth asking is because they have clinical implication. We believe that early diagnosis is good. Is it? Is it always good? And this obviously, if you ask this question, then it has implications for cancer screening. This is the bulk of my lecture will be about that. But I've got a chance to speak to urologists, and I'm going to put a little bit of something that really worries me. I call it a communication gap, but it's not a communication gap. It's more like the Grand Canyon. The gap between pathologists and urologists is huge. I don't think we speak the same language. We don't understand your problems, and you definitely don't understand our language. And I will explain to you why that is so, and what this gap is, why do we have this gap, and how can we sort it out. I think this is something very serious. I'm sorry, I do have a bad throat, so you'll have to forgive me for that. So let's start with what is cancer. Are we all talking about the same disease? I would argue no, we are not talking about the same disease. And the way I look at it is there are three different types of cancer. There's what I call the patient's cancer, the surgeon's cancer, and the pathologist's cancer. And these may be the same, but they may be entirely different diseases. Patients have a very simple idea of cancer. Cancer is life-threatening. So and for a lot of patients, if they're diagnosed with cancer, it is time to write a will. But we know, as doctors, we know that simply is not true. The risk of death from cancer varies from 0%. Basal cell carcinoma of skin, we call it a skin cancer. But no patient dies of it these days. On the other hand, anaplastic carcinoma of the thyroid would be a prototype of the patient's cancer, which is invariably lethal in a very short period. For surgeons, their understanding of cancer is different. There may be a risk of death, but the point is there is a risk of clinical harm to the patient. There's a risk of metastasis, there's a risk of recurrence, there's a risk of harm, but not necessarily death. What about pathologists? When a pathologist talks about cancer, his concept is very different. So here's an example for you. A 44-year-old woman has Graves' disease of the thyroid. The hyperactivity of the thyroid could not be controlled by medical means, so she ended up with removing the thyroid. So the removal was entirely a therapeutic process. There was no suspicion of malignancy. The pathologist slices the specimen, takes and looks at it macroscopically. Sorry. There's nothing to be seen in any of these slices. And we put the Royal College guidelines in the UK are to put a couple of blocks in. So I could have picked this piece and that piece, or I could have picked that and that. But it was the patient's bad luck that I happened to choose this piece as one of the pieces. And what do I find? A small, tiny papillary carcinoma. What is the risk of death? 0%. What is the risk of metastasis of a unifocal papillary microcarcinoma? Is practically 0%. But this patient, as far as the patient is concerned, the patient has thyroid cancer. The patient still has, we have the same name. I don't have a different name for this condition. I call it papillary carcinoma thyroid and then write a long story saying that this is very small, this is well differentiated, etc., and the prognosis is very good, but the bottom line is papillary carcinoma of thyroid. So this is actually very similar to inflammation. Your concept of inflammation as a surgeon is very different from my concept of inflammation as a pathologist. So a surgeon's cystitis is a clinical disease where a patient presents with signs and symptoms. For a pathologist, like when I diagnose follicular cystitis, it only means there are some inflammatory cells and there is some germinal center formation. It's purely often a histological abnormality which may have no clinical significance. So both of us call it cystitis, but we are talking about totally different things. And the same way, when both of us talk of cancer, we may not be talking about the same disease. So the question is, which is the right definition? If we have all these definitions, which ones? And the answer is obviously all of the above. The way it works is all the cancers in practice are pathologist cancers. And most of these currently are surgical cancers, and a proportion of those are patients' cancers, which are lethal. So all of these that we call cancer, the majority of them will cause some clinical problems in the future, but a smaller proportion of them will cause death of the patient. Cancer is not a single disease. It's a diverse group of diseases with very different outcomes. Now, why does this matter? We all, as doctors, I think we all know that when I talk about cancer, I'm talking about different things. But this is how it is presented in the lay press. So this is from the BBC, which says half of the people in the UK will get cancer. What cancer? Is it half the people getting pathologist cancers, in which case it doesn't matter? Or is it half the people getting patients' cancers, which means a lot of people are going to die and need treatment? Now, those cancers are very different. Here's another paper which talks about cancer survival rates 3 times higher with early diagnosis. And then we got all these wonderful things that turn up now. Google is going to change everything. Nano devices can improve cancer detection and diagnosis. But which cancer are they going to detect? Which cancer are they going to diagnose? Are they going to diagnose the clinically significant surgeon's cancers or the clinically insignificant pathologist cancers? I don't think they have addressed that. Similarly, when we talk about pathology going to the dogs, with dogs being trained to treat prostate cancer and trying to take my job, again, what is it sniffing? Is it sniffing the harmless ones or the real cancers? So which cancer are they all talking about? And then you got this question that we've always had this basic dogma that early diagnosis is good. Is that really always the truth? I think for that, you've got to go to vomit. Vomit, it's a very distressing side effect of modern medicine. Now, the radiologists are very good at acronyms, where they use the first letter of things. VOMIT stands for Victim of Modern Imaging Techniques. So today, that's what's happening here. Because as we investigate patients more, we find things. More and more patients get ultrasound. So renal tumors, small renal tumors, which would have never been detected in the patient's lifetime, and the patient would have died happily, blissfully ignorant of it, now has the worry of either the worry of surveillance or the cost of treatment. Similarly, I deal with some endocrine pathology. So when any patient who comes with a neck lump gets a neck ultrasound. And if my neck radiologist, if his hand is not steady enough, his hand kind of wanders over the thyroid gland. If it wanders over the thyroid gland, he finds a small nodule in the thyroid gland. The next thing you know, the patient had an aphanesia of that small nodule. The next thing you know, he's got a diagnosis of papillary thyroid cancer and either a lobectomy or maybe even a total thyroidectomy and thyroxine replacement for life. That's major steps for something that was entirely asymptomatic, and some of those would never have caused any harm at all. So that's something, as a medical profession, we need to think about. This is where we are moving. So this is where the title of my talk comes from, the changing face of cancer. I think cancer is changing, not the management, etc., but the very basic nature of cancer, what we are calling cancer, is changing. In the past, patients presented with breast lumps, and usually patients presented not even with a breast lump. They presented with symptoms of metastasis. So they presented either with a fit, or they presented with weight loss, or a fracture because of a bone met. So obviously, these were all nasty, aggressive tumors, presenting often with metastasis. So these were all patients' cancers. And that, I think, is the reason why cancer has got such a scary feeling to it. We all are scared of cancer because we all think of the cancer that we used to see 30 years ago. The patients, we could see patients dying in front of us. We could see them losing weight. But today, a significant proportion are actually silent. It's like the iceberg under the water. These patients get a diagnosis of cancer, get treated, they don't develop any symptoms, they never develop any metastasis, because even if we had not found the cancer, they would probably not have developed anything. And these patients, nobody knows about them. Nobody even knows that they have got a diagnosis of cancer. And I think it's quite likely that in the future, if we continue the way we are doing with the investigations, etc., and we do not change our terminology, this is what we will end up with, where we are going to end up with a majority of the cancers that we diagnose will be the harmless cancers. For example, we are seeing that in the prostate. In India, the majority of the cancers that you diagnose, prostate cancers that you diagnose, are advanced prostate cancers. They are aggressive prostate cancers. In the UK and the US, we find a lot of harmless cancers because we go searching for it. We go looking for the PSA. We go testing and screening and searching, and that leads to problems. So those are issues. So currently, that may be an issue of the West. But I suspect in another 10 years, it will be a problem for India. And I think India needs to think now how to deal with that problem, not to wait until it happens and then to deal with it. The other point I think we all need to understand is the natural history of cancer. We talk about the natural history of prostate cancer, the natural history of bladder cancer, etc. In fact, the actual truth is we do not know the natural history of any cancer. We do not know the natural history of prostate cancer, bladder cancer, thyroid cancer, anything. And the reason for that is, if you go back to physics, it's called the Heisenberg principle. The Heisenberg principle is that one cannot simultaneously determine both the position and the momentum of an electron. The easy way to explain this is, if you've got a speed gun, you're trying to measure the speed and momentum of a car, you're firing particles and waiting for it to reflect back to the detector. Now the car is very big, the particle is very small, so the particle will not affect the car. But when you do that with an electron, when you fire even a tiny, tiny particle at the electron, it will move the position of the electron. So by testing for the position of the electron, you actually change the position of the electron. And that is why you can never determine both the position and the momentum of the electron. And in cancer, it's exactly the same story. So we've had this debate about Gleason 6 prostate cancer. And there has been some suggestions that Gleason 6 prostate cancer is not cancer at all, because patients with radical prostatectomy and Gleason 6, they do not develop any metastasis. And hence, it's been suggested that we should change the name of Gleason 3+3 into something else other than cancer. So that's basically an article here that says, should we really consider Gleason 6 as prostate cancer? But you can only diagnose Gleason 6 after a radical prostatectomy. Because on a biopsy, I can diagnose 3+3 on that tiny bit of tissue which you have provided me, but I cannot diagnose 3+3 in the patient. So the only time I can diagnose 3+3 equals 6 prostate cancer in a patient is after a radical prostatectomy, if I've examined the prostate in total. But once I have done that, I have affected the natural history of the disease. So there is no way for me to know what would have happened if I had not excised that tumor. And that is true of all tumors. So there is no way for me to know what would have happened to that breast tumor if I had not excised it. If I did not excise it, there is no way for me to know that there wasn't a part of bad differentiation breast cancer which had not been sampled. So that's a catch-22 situation that we have. So we have to understand that our science is not perfect. It has limitations. And then we have the question that is each patient's single tumor, is it a single cancer? So we know as pathologists, we get morphological heterogeneity. So you get you get a tumor, that area is well differentiated, that area is poorly differentiated. If you give me a biopsy, depends, it's potluck. So in that case, each tumor is composed of multiple clones with very different outcomes. So you would have some, if the green is good, the red is bad, there are some good clones, there are some cells which are bad clones. And you give me a biopsy, it just depends which clone happens to be hit. So the pathologist is in the situation of blind man and the elephant. I think it's very, very appropriate that here in Ahmedabad, because as you probably know, blind man and the elephant is a story from Jainism, from Mahavir, is it? So I think it's very appropriate for this state. But that's the situation we are. So what the corollary of this is, just like clinical medicine. In clinical medicine, if a patient presents with brain mets, you don't need a pathologist to tell you that this is an aggressive tumor. Same way, so you can diagnose you can give bad news, but you cannot diagnose good news. You cannot say that this prostate cancer will not metastasize. You can say that it feels hard, it's involving the seminal vesicle, it's very likely to metastasize. Same way in pathology, the pathologist can give bad news. So if we see something like the polydifferentiated component, we can say this is going to be aggressive. But we can't do the reverse because there may be parts of the tumor which have not been sampled. So, and this is not just about histopathology. This is all tests. That includes the most fancy molecular test you can think of. So whatever molecular test you do can only tell you about the cells that you have sampled. So if there is another clone which is nasty, which has not been sampled, whether you do Oncotype DX, you do whatever next generation sequencing, the most expensive test you do, it will tell you nothing about the clone you have not sampled. I like to joke that to my knowledge, there is only one tool that has been invented by God to detect, to identify the clone that has not been sampled. My wife, who's a histopathologist. It's called feminine intuition. So other than feminine intuition, men have no chance. Okay, so this is the point. The point is, but you've got to understand that when pathologist gives you, it's not a final diagnosis. We can only give you an opinion on the bit that has been sampled and not about the rest of the tumor. So moving on now to benign and cancer are these different diseases. Now this again is important. So this lecture, what I'm trying to talk to you about is I'm not trying to teach you pathology. This has got nothing to do with pathology. This is about clinical medicine. This is about understanding cancer in the clinical context, not in the pathological context. So we have always been brought up to believe that cancer and benign is a binary dichotomy. But what is it actually, what you have? You've got a 0% risk of metastasis for the benign and then increasing risk of metastasis for the cancer. But at what risk of metastasis would you call something cancer? Would you call it for any risk of metastasis? We know that at this end we would say this is good cancer, at that end we would say bad cancer. Okay, and we know that good cancer and bad cancer is a clinical continuum. But what about this one here? When I say there's a less than 1% risk of metastasis, well, that's not 0% risk of metastasis. There is a risk of metastasis, but that's no worse than benign. So what cutoff do I put? Do I put 0.1% risk of metastasis, 1% risk, 2% risk, 5% risk, 10% risk. And why does it matter? Because what we are having here is trying to find the balance between specificity and sensitivity, between overdiagnosis, underdiagnosis, between undertreatment and overtreatment. So if I put this number very low, the cutoff, and say a 1% cutoff, that means I will be overtreating a lot of people. When I say overtreatment, surveillance is also overtreatment. If I diagnose somebody with cancer and put them on active surveillance, the amount of psychological stress it causes, the financial implications for insurance and other implications that it has is very, very significant. The fact that we didn't operate on them doesn't mean that we have not subjected them to harm. On the other hand, if I use a high cutoff like 20%, yes, I could well end up under-treating. So the point I'm trying to make here is there is no line there. So again, this is just an arbitrary. Each of us have a different perception of risk. Each pathologist has a different perception of how much risk. So when I'm talking about an oncocytoma versus a chromophobe, so it is not just a pathological distinction, it's a clinical distinction as to how much risk should be there before I label this patient as having cancer. And moving from that, is early diagnosis of cancer always good? Now for this, I will have to teach you a little bit of pathology, or a little bit of pathogenesis, a little bit of science. So what we believe is, so suppose all cancer starts from one cell, that's what we believe. And as the tumor increases, it becomes bigger, and if this is a size at which the cancer produces symptoms. The cancer then continues to grow, and this is the size at which it causes death. And on the x-axis, you've got time. And fortunately, none of us live forever, right? And so we will always, there's a question of heart disease, stroke, all other causes of death. Now you've got some tumors that grow very, very quickly. They will become a size, they'll become symptomatic, and they will cause death. There are others that will grow more slowly. They will take several years to become symptomatic, and then they will go on to cause death. But some of these are growing so slowly that they will not cause any death in that patient's lifetime. And then we do not know why, but we know that there are cancers that grow and then for some reason stop growing. Now, what we do not know is whether there's a mutation. So just like you can have a bad mutation, whether you can have a good mutation. So whether you can have a mutation that stops the tumor growing. Now that's, in my opinion, that's less likely, because in a tumor you've got multiple clones. So it's unlikely that all the clones will get a good mutation. The other possibility is obviously the immune status of the patient, that the patient's immune status has done something which now keeps the tumor under control. So we've got these 4 different types of tumors. Keep this in mind, because I will be coming back to it later. These 2 are the ones which are clinically significant. So these are the ones which are going to cause problems for the patient, while these 2 are the ones that the patients will die with. So these are clinically insignificant cancers, and which basically pathologists will call cancer. But if you look at this and think about it a little further, this time is variable. None of us know how long we will live. So suppose I've got, now the example I would give you is a gynecological one, a granulosa cell tumor of the ovary. The short-term prognosis of the 10 years, 15 years prognosis of granulosa cell tumor is very, very good. The long-term prognosis of granulosa cell tumor is not very good at all. Patients come back with late metastasis and they do harm. So if I've got a 30-year-old woman, that is a clinically significant cancer. But the same tumor, exactly the same tumor, same features in a 70-year-old woman is probably not going to cause any harm in her lifetime. But I do not have a language. I do not have a different name to give that granulosa cell tumor in a 30-year-old and a 70-year-old. In both of them, I call it a granulosa cell tumor. So this is why we have got limitations of our science, and we got limitations of our communication. And you can see what this leads to. So this is a graph showing the blue bars is the incidence rate per 100,000, and the dark blue is the mortality rate. And if you compare these, so look at USA, that is the incidence and that is the mortality per 100,000. So one of two things: either most people in America most men in America would have been dying of prostate cancer because we found them and we treated them and we saved all these lives, or else we have harmed a lot of people by detecting harmless prostate cancer. And you can see where India is down here, where it's very different. And this is partly because we don't screen patients for PSA in India. And tomorrow, if we do start screening for patients in India, we could end up with something like this. And that's entirely possible. And that, again, we have to keep in mind. And this, again, I've been talking about this for at least 10 years, about this problem with prostate cancer, and in general, about what we are calling harmless cancer, etc. And I was, well, not a maverick, but I was certainly an outlier. I was saying something new or something unusual. Today, I'm sorry to say, I don't know that I like it, but I have become mainstream because other people have joined. So now there is, even in the US, there is a huge push to take the name cancer out of many tumors. They have got this indolent lesion of epithelial origin, IDLE is what they call it. So the idea is not to call these tumors cancer, but to give them a different name. Because name does matter, because it matters to patients. I think all the nurses that I talk to, all of them say the same. That when they talk to patients, and I think I'm talking to the wrong audience here, because you all know it better than I do. Once you say the word cancer, patients go blank. It's like a mask. And then you can explain to them all you want about being good cancer and the good risk, etc., but nothing is taken in. They want to be treated. They want it out. They don't want to live with that tumor, even when you tell them it's a very low-risk tumor. And that's why the argument is maybe we need to start by changing the name and not calling it cancer to start with. And here's what we are seeing in the UK. So there was a slow increase. But here, what happened there? PSA. So that's when we started doing PSA screening. The incidence has zoomed. The mortality has fallen slightly. But don't forget, there are significant advances in the treatment of prostate cancer, in the treatment of metastatic prostate cancer. So this fall in mortality can be very easily accounted for by improvement in management rather than improvement by early detection. So this has implications for cancer screening. The reason it has implications is because what does screening do? So whether you're doing breast screening or cervical screening or prostate cancer screening, you're doing it every 1 year, 3 years, 5 years, whatever your screening interval is. These cancers, the fast cancers, the really nasty cancers, the cancer that's going to really kill the patient is not going to be picked up by screening. Those are what we call the interval cancers. They appear between the two screens. The bulk of the screening cancers, the ones that will be picked up by screening, are these three. And the more times you screen the patient, if you screen the patient every 2, 3 years, if you do annual PSA from the age of 40, the chances are at some stage you will find a slight rise in PSA, you will do multiple biopsies, you will find some prostate cancer. And you're much, much more likely to find these pathologous cancers by screening. So screening does disproportionately identify the clinically insignificant pathologous cancer, and that is a problem. And so this is what we have. So we are walking a tightrope here between underdiagnosis on one side and overdiagnosis on the other. We are afraid of undertreating patients. We are afraid of overtreating patients. So this is where, so in a way, this is where the pathologist is worrying between underdiagnosis and overdiagnosis, and this is where the urologist is worrying between undertreatment and overtreatment. But what's interesting is when you look at the impact of this, of underdiagnosis, overdiagnosis, undertreatment, overtreatment. Underdiagnosis, what happens? There's serious harm if the patient develops mets. Underdiagnosis is easy to identify. So if I don't treat the patient and the patient comes back with mets, we probably we've undertreated the patient or underdiagnosed the patient. And the net effect of that is an upset patient, because the patient is absolutely convinced, if you had only treated him, if you had done the prostatectomy 3 years earlier, I would not have had the metastasis. What about overdiagnosis? Very different. I need to make the point, when we talk about overdiagnosis, this is not the same as a false positive, as a histological false positive. Histological false positive is an error where the pathologist has wrongly interpreted a case as malignant. Overdiagnosis is not a wrong diagnosis of cancer. It is a correct diagnosis of cancer, but it is a clinically insignificant cancer in that patient. So that's different. So that's basically the official, the official definition. Overdiagnosis is detection of cancers that would not have caused problems in that particular patient's lifetime. The diagnosis is correct, and these patients are generally treated. False positives is a diagnosis that is proved to be wrong by a second, more precise test, or often a more precise subjective opinion. So when I give a second opinion as an expert, it's only an opinion. So my opinion, I hope, is more often right than the practicing pathologist's opinion, but not always, right? And so this is an error, and this would, if it's been detected in time, the patient would not be treated. So what is the impact of overdiagnosis on the patient? So again, the point here with overdiagnosis, the problem is not with the pathologist, it's not with the scientist, but with the basic science. So here there is a risk of serious harm, psychological, and the effect of treatment. It's almost difficult to diagnose. You don't know who you have overdiagnosed. So because we called all these things cured cancer, and the patient is extremely grateful, even if the patient has got incontinence and impotence after radical prostatectomy, he says, I can live with the incontinence because otherwise I would have been dead because of the metastatic prostate cancer. But that was actually an overdiagnosis. He's living with incontinence for something that he didn't need at all. And we know that in America now, the radical prostatectomy rates have more than halved, because this has become the general norm now. It's accepted that we have been doing excessive surgery on these patients. What is more interesting than that is how we perceive overtreatment and undertreatment. Because underdiagnosis and undertreatment is invariably overestimated. Because we assume that earlier diagnosis and treatment would have saved this patient. So this patient who comes with metastatic prostate cancer, we assume that if he had picked it up earlier, he would not have developed metastasis. But it's quite likely he had micrometastasis already 3 years earlier. So we overestimate the incidence of underdiagnosis and undertreatment. And on the other hand, we underestimate the frequency of overdiagnosis and overtreatment, because we attribute it to our wonderful ability to detect the cancer early and treat it early. So this is why we have this paradox. If we have in the UK, we have the breast screening program, the cervical screening program, and the worse the screening program, the happier everyone is, which is weird. No. So you would think that the worse the program is, people would be unhappy. No, a bad screening program makes people happy. Patients think they've had their lives saved. Surgeons think that they have been saving people's lives. Politicians are very happy because there's a lower mortality rate, higher survival rates, and they think they've got a better health system. Because if I find a lot of harmless cancers, so I showed you this one earlier, cancer survival rates 3 times higher with early diagnosis. Yes, because if I find a lot of harmless cancers, the survival rate will go dramatically better. So this is why we get this paradox. So just because the 5-year cancer survival rate is improved doesn't mean we have benefited patients. The only way we know we have benefited patients is if the absolute mortality rate, if the mortality rate per 100,000 dying of prostate cancer falls, then we know. But the problem is we never know whether that is due to diagnosis or due to better treatment options. And that's why that's much more difficult. So you get this situation, worse the program, higher the satisfaction level, but the patients are actually harmed. And I think this is again something that we need to think of. And this is not just if you don't need to have a screening program for this. even when a patient comes to you, even when there's no screening program, comes with a PSA test or whatever, as far as that patient is concerned, it's the same thing, whether overdiagnosis, whether it's part of a screening program or it's part of an individual test. So these are things that as clinicians you need to think of, and as pathologists, we also need to be part of the discussion. And this is a vicious cycle because you get overdiagnosis, higher survival rate, the politicians are delighted, more money put into the screening program, higher satisfaction, more screening, and even more overdiagnosis. And you get this vicious cycle. So again, this is something we need to at least look at, we need to at least think about it, we need to at least talk about it. We can't ignore it, which is what we are currently doing in the West. So the question we always have is to screen or not to screen. That is the question. That's how Shakespeare would have put it. But that is not the question in pathology or in clinical medicine. The question is not whether to have a breast screening program or not to have a breast screening program. The correct question that we need to ask is who should we screen and what should we screen for? Because if we screen only the higher risk group of patients and only for the higher risk lesions, then you will do less harm and you will do more good. Yes, you will miss some patients that you could have saved, but you will save harm for a large number of patients, and the net good will be better. Sorry. Okay, so now moving on to the next bit. Now this is a little bit of pathology here, but again, I'm not trying to teach you grading and staging. What I'm trying to explain to you is to understand grading and staging, which is very different from learning grading and staging. So we all, as I explained to you, benign and cancer, these terms are too imprecise. So we need to stratify patients. And so we risk stratify patients using grade and stage. So how do we do it? So here's the renal cell carcinoma staging. We know T1 and T2 with a cutoff of 7 centimeter. Up to 7 centimeter is PT1. More than 7 centimeter is PT2. Clear cut. But why 7 centimeter? Why not 6 centimeter? Why not 8 centimeter? Why not 9 centimeter? Why not 9.2 centimeter? Have there been studies looking at 6? No, because one study did, and in that cutoff, the 7 centimeter cutoff worked. So all the other studies use the 7 centimeter cutoff. Okay, so these cutoffs are entirely arbitrary. In a lot of, like Gleason, we use the 5% cutoff and the 50% cutoff. Where did the 5% and 50% come from? It's easy to remember. I can remember 5%, 50%, 90%, which are the three cutoffs that we use for percentage pattern 4 to decide whether it's 3 plus 3, 3 plus 4, or 4 plus 3 and 4 plus 4. So these numbers have been only created by us. The tumor doesn't recognize, the tumor doesn't say that when I've got more than X%, I will behave differently. So these are entirely artificial. So but the important thing here, we all recognize that grading and staging is a morphological. Under the microscope or for the pathologist, it is a continuum. But what the pathologist also has to understand, that this is also a clinical continuum. A 71 millimeter tumor, that would be T2, is not more aggressive than a 69 millimeter tumor, that is T1. So when we did a study and said, I don't have it there. But when we did a study and said 7 centimeter cutoff, the T2 behaves differently from T1, what we mean is that a 3 centimeter tumor behaves differently from a 10 centimeter tumor. The ones that were borderline, the 5 millimeter cancel these 8 millimeter. So those ones will cancel each other out. So what those statistics actually tell you are nothing about the borderline ones, not ones near the cutoff, but the ones further away. So the problem we have is we don't do the same with grading. With staging, when I give you the tumor size, when I say T1 or T2, I don't report a renal cancer as PT1 or PT2. I say 69 millimeter T1 or 71 millimeter T2 or 151 millimeter T2. So the surgeon clearly knows whether this T2 is an obvious T2 or is a borderline T2. But when it comes to grading, it's the same thing. A bad low grade is not just a morphological continuum, but it's a clinical continuum because it is not biologically different from a good high grade tumor. So there is no cutoff. The behavior of a good pattern, Gleason 6, is no different from a bad Gleason 6 is no different from a good Gleason 7. So that's why these cutoffs are arbitrary if I take the risk of extraprostatic extension. So when you ask me, Murli, what is the grade of this tumor? Is it Gleason score 6 or 7? I should be turning to you as a urologist and asking at what risk of EPE would you consider Gleason 6 to be Gleason 7? So if you're saying that you're going to do a bone scan when it is Gleason 7, at what risk of EPE would you do a bone scan? There is no answer to that. And because there is no answer to that, there is no line to be drawn between Gleason pattern 3 and Gleason pattern 4, or Gleason pattern 4 and Gleason pattern 5. So what we are actually telling you is not whether it is here or here, but it is somewhere here, somewhere here, somewhere here. And as I will explain to you, we don't communicate that very well. Sometimes, I think it is what pathologists are actually doing is hiding information from the urologist, which I don't think it's right, and I don't think it's necessary. So as I said, we report tumor stage, or renal cell carcinoma stage, with both millimeters and the stage. But when it comes to grade, it is a continuous variable. But we treat that continuous variable as a discrete variable and report it, if it's a bladder cancer, as either low grade or high grade. So Gleason score 3 plus 4 equals 7. This could be a case that I spent time worrying whether is it pattern 3 or pattern 4. Today, I felt brave. I called it Gleason pattern 4. You show me the same slide tomorrow, I might call it Gleason pattern 3. We all know that. However expert you are, all the experts know that, right? Because there is no line there. So depending on my mood, depending on what's happened before, if I have called 3 consecutive borderline cases Gleason 6, I might find a reason to call the next one Gleason 7, because I feel I'm getting into a rut. Right? So this patient, why should he have surveillance, not have surveillance just because today was my Gleason 7 day, when if you had shown it to another expert, or you show it to me on another day, I would have called it Gleason 6. So this patient is entirely suitable for surveillance. So this patient, 3 plus 4 equals 7, borderline, can have surveillance. On the other hand, I would have a case where I've been worrying, there's very little gland formation. But the definition of Gleason pattern 5 is there is almost no gland formation. Now what is almost no? It is subjective. So one day I would say that this is almost no sufficient for pattern 5. But today I was not so brave. And I said, not enough, and I called it pattern 4. There was still a lot of pattern 3. I called that 3 plus 4 equals 7. Now, these 3 plus 4 equals 7 are very, very different. But what does the urologist say? This. So it's the same thing. So this Gleason 6 and this Gleason 6, sorry, this Gleason 7 is no different from a Gleason 6. This Gleason 7 is very, very different from a Gleason 6. But what does the surgeon see on his report? Gleason score 7. How is he supposed to know whether the patient is here or the patient is there? Unless the pathologist tells him. Because this is the difference between radiology and pathology. As surgeons, you don't just look at the radiology, sorry, I've lost that there. As surgeons, you don't just look at the radiology report. You look at the MRI scan, you look at the CT scan, but you don't look at the histology slides. You are depending entirely on our written word. And that is why, as pathologists, I think it is absolutely incumbent on us that we have to provide you that information in the written word. We can't say that we can leave it to the MDT or whatever. No. Otherwise, don't bother to report anything. Why bother to say anything then? Why grade the tumor at all unless you're going to stratify the patient properly? So that urologists cannot distinguish these scenarios from the written report, so the pathologist has to provide that information in the written report. And so this is why I say there is a chasm here. There is a big gap in communication between urologists and pathologists. So if we talk about what gap and why gap, at the end of the day, radiology is anatomy. Most surgeons know the shape of the kidney, they know the location of the kidney, they know where the liver is, so that is all anatomy. So, and in radiology, you're looking at anatomy, so surgeons are very comfortable looking at radiology pictures. And for that reason, surgeons view and interpret X-rays, CT scans, MRIs, etc. But pathology is different. Because pathology is histology, and histology is imaginary. I look at things and I have to imagine things. I am looking at a three-dimensional structure in 2 dimensions and imagining it. So I don't see a cell. I have never seen a real cell or a real nucleus. I'm imagining it. And yes, there's something staining dark blue. There is something staining more pink. The stuff that is staining more pink is cytoplasm, and the stuff that is staining dark blue, and the dark red within the dark blue is a nucleolus. So that is all in the mind. And for surgeons to do that, the imaginary stuff, when they don't look down the microscope, is almost impossible. And that's why surgeons will not. So surgeons don't do histology. So if you see a surgeon at the microscope, he's doing a robotic prostatectomy. That's the only time you're going to see him at a microscope. So the point here is surgeons do not need to be able to interpret histology. There is no need. So in your urology exams, there's no need for you all to be examined on examining histology. Why do you need to do it? The same way when we, in our tumor board meetings, many pathologists tend to show urology pictures and histology pictures. And my experience is I start showing histology pictures, the surgeon picks up the notes and starts reading about the next patient. He's not interested, and quite rightly, why should he be interested? So my point is, there is no need for the surgeon to be able to interpret histology appearances, but he does have to be able to interpret the pathology report. So what the surgeon needs to be trained to do is not to interpret what the cells look like, or what Gleason pattern 3 looks like, or what Gleason pattern 4 looks like, but when I say Gleason pattern 3 or Gleason pattern 4 in the written word, to interpret the written word and how to interpret those written words correctly. And that is absolutely essential for clinical practice. And I'm afraid many clinicians have very limited awareness of the pitfalls and limitations of pathology. There are 2 reasons for this. One reason is got to do with undergraduate teaching. When you learn radiology, the radiologist doesn't open his cupboard and take a collection of classic X-rays to show you. When you go to learn surgery, the surgeon doesn't bring actors to act as if he's got a kidney tumor or whatever else. You see real patients. You see the surgeon dealing with real dilemmas. But when we teach undergraduates pathology, we don't teach them surgical pathology. We teach them pathology as a basic, only the obvious ones. We don't teach them the borderline stuff. So we should be teaching undergraduate students how to interpret pathology, surgical pathology reports. And I'm afraid that is our failing as pathologists, that we haven't done that, and that's what we need to move to. So when you look at how do pathologists do what they do? 2 views. There is the urologist view of pathology, which is, it is the final diagnosis. And the pathologist view of pathology, which is exactly like clinical medicine. Clinical medicine is you're providing an informed opinion. That's all it is. When your diagnosis is an informed opinion, and so is mine. So when I give you a diagnosis, it is just an informed opinion. And so how do pathologists do it? I think there are 2 types of surgeons, in my opinion. There's one type of surgeon who believes that it's all very simple. I've been to med school. I've looked at histology slides. I know tissues are made of cells. And in the middle of the cells, there is a dot, which I was told is a nucleus. You look at it under a microscope, there will be a B for benign and M for malignant. And all you need is a microscope. So provided you've got a pathologist with good enough eyesight who can currently identify the B and the M, you're okay. The second group of urologists who believe this is black magic. Nobody can understand it, how these pathologists do this. Right? It's one of those mysteries. It's neither. It's what we are doing is very simple. What we are doing is pattern recognition. So we are comparing something, looking, does this look like that, right? So, which is why you end up with pitfalls. So here you've got 2 insects, right? Or if you want to call them 2 tumors. These 2 tumors look very similar. Both of them have got yellow backsides with a black stripe, legs. They look very similar. So if I've got an inexperienced pathologist, he would say that these 2 are the same. A more experienced pathologist would look at it a little more carefully and say, that is slightly different from that. Maybe this is more bulbous or rounded, while this is more oval. And the experienced pathologist may see some subtle differences. This is what we get in a biopsy. But when you give us a whole tumor, then you don't need an experienced pathologist to say that one is a spider and the other is an ant. Okay? So this is what you have in pathology. It all depends on which bit of the insect or the tumor we happen to get. We may get an obvious bit and make the diagnosis, or we may get a tiny bit which we can't. But then we have this. So this is where I scared my urologist. I said, Owen, that's my urologist. I said, when I diagnose prostate cancer, all I mean is the patient has got a condition which has the histological features of prostate cancer. If there is a benign mimic of prostate cancer that under the microscope shows all the features of prostate cancer, I will call it prostate cancer. And this is the same. So in a way, a pathologist is like an eyewitness to a murder. So if I see a murderer, and then if the murderer is an identical twin, yes, I will identify the identical twin as the killer. So it's exactly the same case. So why do you need to know this? Because the reason you need to know this, always interpret the path report not as a final diagnosis, but in context with the clinical situation. So if you've got something that is behaving that is clinically suspicious or aggressive, just because the biopsy says it's benign, you can't assume that that's benign. Now this is the only pathology histology slide I think I have in the presentation, so you will have to take my word for this. This is a biopsy of thyroid tissue. You show me this biopsy, I will report this as normal thyroid tissue, right? So this is benign normal thyroid tissue. The only problem is it's a biopsy from a metastasis in the vertebral body. It's metastatic follicular carcinoma of the thyroid. I know it's metastatic thyroid follicular carcinoma not because of the histological appearances, but because where it was. But if the same tumor was if this was a biopsy from the primary, there is no way I can diagnose it. So you have to understand that histopathology has its limitations, right? And that's simply part of it. The other way of explaining to clinicians about pathology is to compare it with something they're more familiar with, that's radiology. So if you compare pathology with radiology, I would argue that pathology is a lot more challenging than radiology. And the reason for that, well, I'm in India. T20 is going on. So we'll talk cricket. The radiologist is a third umpire with a sneakometer. He is looking to see whether the ball has touched the bat or not. That is an absolute thing. Has it touched? Has it not touched? The pathologist is a third umpire sitting there and trying to figure out, after it hit the pads, would it have hit the stumps or no? That is guesswork. So there involves a bit of guesstimate. And that's what pathologists do. Or a simpler way of looking at it is the radiologist is telling you about today's temperature. He's telling you that it's 26 degrees today, which is 3 degrees higher than yesterday's temperature of 23. Both of those, he had looked at the temperature yesterday, which was 23. He looked at today's temperature, which is 26. The pathologist is trying to tell you what the temperature will be like 20 years from now. He's trying to tell you not what the size of the tumor is today, but what the size of the tumor will be like 10 years from now, or what the tumor is going to do 10 years from now. And that is always going to be harder and is always going to be more subjective and prone to errors. So how do we bridge this gap? So there is no doubt there is a significant gap between surgeons and pathologists. So how do we bridge it? More meetings, not showing you histology slides, but explaining to you the path reports. We need to, I think the other side, the communication gap is not one way. It's a two-way process. I think as pathologists, I always tell my trainees to spend some time reading the clinical guidelines so that you know how the pathology is actually used in real life. Then you know that patients, like for renal cancer, you put patients into low risk, intermediate risk, high risk. So just because I spent half an hour and found one additional factor, risk factor, which will still leave the patient in the low risk group, it doesn't matter. You don't have to worry. If it's going to move the patient from the low risk to the intermediate or the intermediate to the high risk, that's when you should worry. Now that's for pathologists to know. And then education. And this is what we've been doing. We have started this recently in my department. So what we have done is we get one day, the urology trainees spend a day in pathology. So in the morning, they have lectures from, there's one of the consultant urologists does a welcome and an introduction, and the pathologist general principles, which is what I do, and then we talk very general, not details of pathology. And in the afternoon, we take them down to the lab, show them how the processing is done, we show them how specimens are cut up, the issues with macroscopy, and all I can say, the feedback that we have got from them is extremely positive. And what we are planning to do is to conduct this once every 3 years, so that every urology trainee in our hospital will have 2 days of pathology training during his training cycle. And I think that sort of thing, will bring both sides. It will help us to understand your needs better and help you to understand our needs better. There is another communication gap now. The communication gap between patients and pathologists. Because in the old days, the way it worked was like this. I reported, say I said Gleason 7. The surgeon did not tell the patient that you've got Gleason 7 prostate cancer. He said you've got good prostate cancer, or you've got intermediate risk prostate cancer, or you've got bad prostate cancer. Today it's different. Today patients read and interpret pathology reports, and unfortunately it's with the help of the internet, which can often be more confusing. Now I'm going to, this is the last few slides in my presentation, and what I'm going to show you how pathology practice has changed, not because of urologists, not because of clinical management, but because of patients' practice. Because patients read our reports, we have changed the way we report. So this is how we used to report Gleason. So we used to report Gleason scores, and put it this way, close your eyes, imagine you're not a doctor. Imagine you have not done medicine. You have been diagnosed with prostate cancer, right? You go on the internet, the Gleason score is from 2 to 10. You've got a Gleason score of 6. What do you assume? You're bang in the middle, or you're slightly worse than the middle is 5. I've got 6. I'm on the worst side. But 6 is the lowest score that I would give on a prostate biopsy. So that caused major problems for patients. So which is why in 2014 we had this consensus meeting in Chicago, and then we adopted a new so-called new grading system. This has been adopted by the WHO in 2016. I'm sure you're aware of this, where we've got the grade groups 1 to 5. Gleason score 2 to 6 is grade group 1. 3 plus 4 equals 7 is 2. 4 plus 3 equals 7 is 3. 8 is 4. 9 to 10 is 5. I'll talk a little bit more about it tomorrow. But basically, what is this? This is a way of grouping Gleason scores, which we have always done. Pathologists have reported individual Gleason scores. Urologists don't have a separate treatment for Gleason pattern 4, Gleason pattern 5, Gleason pattern 6, Gleason pattern. No. You put patients into low risk, intermediate risk, high risk. So with this new so-called new grading system, it is not a new grading system. There is no new information in the PATH report whatsoever. Right? Because if I give you the Gleason score, you can derive the grade group. In fact, when I report the grade group, there is less information than there is in the Gleason score, because when I say Gleason score 5, grade group 5, it could be 4 plus 5 equals 9, 5 plus 4 equals 9, or 5 plus 5 equals 10. And you could quite reasonably, and that was the argument, that it doesn't matter. Pathologists are wasting time distinguishing between these 3 groups, because they all treated the same way, behave the same way, nasty disease. So this is an instance where we changed the grading system for prostate cancer, not for the sake of urologists, because urologists already have this information, but for the sake of the patients, to make our reports more patient-friendly. So to conclude, cancer is a group of diseases ranging from the lethal to the harmless. More widespread radiological investigations has resulted in a dramatic increase in the incidence of harmless cancers. Cancer screening is associated with overdiagnosis and overtreatment. Cancer screening saves lives, but cancer screening also harms lives. Benign and malignant are not discrete entities. They are a morphological and clinical continuum. They're a biological continuum. Tumor grade and stage are continuous variables, morphologically as well as clinically. Unlike radiology that documents current status, pathology is also trying to predict the future. Pathology diagnosis, just like your clinical diagnosis, is a subjective opinion. There is a significant communication gap between clinicians and pathologists. It's not just surgeons and pathologists, it's all clinicians and pathologists that we need to work to reduce. Pathology reports need to be more patient-friendly. I think this is, again, there's a point here. Pathologists can no longer assume that we can write anything we want in our reports, because patients will read it and you can end up with causing anxiety by things that you write on your report. With that, I thank you for your attention. That either means I've totally confused you, or everything.
No, I think you have made it quite simple, and you have made it really for us to understand what exactly is the interpretation. And one thing I can derive, that at least from your lecture now I have understood that in pathology there is no cutoff, and in pathology there are no borders. I think that we have really understood, and I think that is very, very important for us to understand.
And with some luck we will also remove the borders between urologists and
yes, that I think we will continue to remove those borders in the next 1.5 days. So once again I thank you very much on behalf of Majubhai Patel Urology Hospital. This was one of the really very interesting and a very informative lecture. Thank you for coming here and delivering this session of Pulse of Wisdom. Thank you.
I enjoyed it. Thank you very much. Thank you.